Thank you, Srinivas. Wonderful session. In fact, by delaying, you gave us an opportunity to listen to some of the good talks. I wish all of you, like Srinivas, Dr. Ravi, Kulkarni, everyone, just stay back and listen to this another session, which is one more well-drafted, wonderful session. Heading is My Lesson for the Year. That is, the lesson is the COVID has taught us, or the COVID-related issues which has taught us in 2019 or 2020, 21. So there are wonderful speakers lined up. I would, without wasting much time, I would like to start with my first talk by Dr. Anaga Herur. Okay. And the second thing is that all the panelists in this session, please stay back and please be interactive. It doesn't mean that only the moderator should speak. Please give your tips and expert opinion on the talk. Thank you. And Dr. Anaga, please start your session, madam.
Yes. Can you see the slide, please?
Yeah, fine.
We need to introduce Anaga. Can I introduce Anaga?
Yeah, please go ahead, sir.
So, Dr. Anaga Arur is the medical director of Anil Eye Hospital in Mumbai. She is also the academic and research committee member from West. She's very, very active, I should say proactive, in all the academic and research committee programs, and she is very well known throughout the country. She has made several presentations nationally and internationally. Dr. Anaga Arur, please.
Thank you so much, everyone, and thank you for inviting me and giving me an opportunity to interact with you all. So without further ado, I would like to start. So these are some lessons that I have learned over the last 1.5 years from the coronavirus pandemic, and I would be speaking to you all on mask-related problems. So life isn't about waiting for the storm to pass. It's about learning how to dance in the rain. So we all have gone through a grueling experience due to the COVID and the lockdown situations. In fact, I remember when we were under lockdown, cataract surgery patients refused to actually even come for a follow-up. And all of us had found that there was a greater incidence of mature cataracts, dense brown cataracts during the COVID period. We all know how we had to go through RT-PCRs, wearing PPEs, and during surgeries, this became the new normal, using sanitizers, temperature checking, and masks has been now the new normal. And even today, we are all going through it. Now, there was this very interesting article about the challenges of wearing face masks in ophthalmology. If you look at refractive surgery patients, now this because of the mask, there is a lot of fogging of the glasses, and this gives them one more chance and one more reason why they need to undergo a refractive surgery. And because of the extra time that they had during the COVID lockdown, they found that more and more patients were coming to us for this surgery. Plus, there was this mask-related dry eye, which was causing them this problem. Now, what new thing that we learned during this COVID-related, mask-related complication was when I had a patient of femtoLASIK. Look at this video. So this was a patient where I am using the intralace. We have docked the patient, and look at how the patient's breath, exhaled breath, is actually the wave of breath is actually going up and down. And you can see how this entire area, the steam has condensed on a part of the patient interface. Only this part of the laser is actually fired, and because of the steam condensation, this has interrupted the femtosecond laser delivery. Because of this, we had to abandon the procedure and take up the patient for a blade LASIK. In fact, we actually reported this as an online case report, and this has been published in the Journal of Cataract and Refractive Surgery in the volume 10, issue 1. Now, this was a very important kind of complication which we need to remember, because in this case, we had actually even taped the upper part of the mask, but because of the sweat and because of the cleaning with the povidone iodine, this caused a greater amount of loosening of the mask, and that is why the tape, and that is why the breath that was coming out could actually escape from on top of it. So we have to be really very careful regarding all this. The second part is the ocular surface diseases that has been increased because of the digital eye strain, increased exposure to digital technology, work from home in all professions, including children, because of the increased exposure to online classes. So there are two parts to it. One is the increased velocity of the breath that comes out. Now, this mask related dry eye has been a very, very important condition. As I said, two important conditions. One is the increased velocity of the breath, and second is the temperature, which is at around 36 to 37 degrees. This movement of air causes a decrease in the tear meniscus height, increases the propensity of the eye towards dry eye, reduces the T-bud time. So you can ensure a well-fitting mask, consider taping of the top edge, use lubricating eye drops, or even take regular breaks. But however, people who have used and who are going to use masks for a longer time, more than 6 hours at least a day, could face greater problems. Now, this very important article where they studied the face mask related ocular surface modifications, including in vivo confocal microscopy and impression cytology studies, along with the dry related questionnaire to look at the quality of life. So what they compared was one group number one, which was dry eye disease, with group two, which was healthy subjects. And they had divided it into three groups: less than 3 hours, 3 to 6 hours, and more than 6 hours of fast face mask. They also compared the T-bud time, the Somas test, the fluorescein and Lissamin stain, and the IVCM to determine the corneal dendritic cell density, goblet cell density, and the impression cytology to measure the HLA-DR. Now remember, friends, the corneal dendritic cell density and the HLA-DR expression on the conjunctival epithelium are biological markers and for inflammation, especially in dry eye disease. So they checked this at baseline and at 3 months. Now, if you look at the data that they have, if you look at the DEQS in the dry eye group, it increased from 48 to 50, and the T-bud reduced from 4.1 to 3.8. The fluorescein stain and the Lissamin stain also increased. Also, this was the same thing in healthy subjects. So all the values were 4 times worse over 3 months. Now here you can see how the Lissamin green stain has increased on the conjunctival bulbar epithelium, especially after 6 hours of wear of face mask. Now, very interestingly, the in vivo confocal microscopy showed the dendritic cell density from 58 to 62 in the dry eye group, as well as in the healthy subjects group from 19 to 22. The HLA-DR increased from 40 to 43 and 5 to 6 in the dry eye and the healthy group too. So this is the representative image of the dendritic cells, how it has increased from the baseline to after 3 months, how the goblet cells have reduced, and this is the HLA-DR expression, which has increased in especially the dry eye disease group. So what is the take-home message from this is, one, in dry eye patients, already the quality of life is impaired, plus because of the face mask, is greater ocular surface inflammation as the main mechanism of action. So you need to detect and treat early, counsel them well, have good medical and behavioral strategies, use of lubricants, IPL, monitor these patients regularly. Now, even simple things like refraction, a lot of patients may not even be aware, especially in children, that because of the fogging of the refraction during refraction, sometimes they may not achieve their best corrected visual acuity. Now, even in patients who are doing perimetry, for example, the visual fields could be unreliable because of the mask. Sometimes people wear really huge masks, and that is why the chin actually doesn't sit properly on the perimeter. You can have fixation losses. And look at this here, there could be a lot of misinterpretation because of either, it can mimic the new visual field defects or increase in the pre-existing field defects, all because of the mask. So here you can see the distance of the upper surface of the mask from the eye is 1.5 centimeters or 0.5 centimeters with or without the nose clipping. Again, there could be fogging of the trial lens. Simple problems like wetting of the mask due to anesthetic or mydriatic or fluorescein drops in the OT due to the povidone iodine preparation. There could be staining of the mask. All this can cause patient discomfort. More importantly, this was an article which said that patients wearing face masks could be at a risk of endophthalmitis much higher because of the face mask. One, because of dispersion of the airborne particles, including bacteria, towards the eye. Second, probably it could actually impede the proper preparation of the periocular area with povidone iodine, or sometimes because of the huge mask or the N95 mask that they were wearing, it could cause contamination of surgical instruments or surgeon's gloves by the patient's face mask. All this leading to increased risk of endophthalmitis. very interestingly, this was a video which showed condensation of the patient's exhaled breath on the haptic of the intraocular lens, which can be really a matter of concern. So what we need to do is to learn how to tape these face masks onto the patient's midface very, very properly, in both for refractive surgery patients, especially if you're using femtoLASIK or SMILE, as well as in cataract surgery patients. So dry the patient's skin thoroughly, press firmly when applying the adhesive, hold one hand down and then toss the drape towards the patient's waist, and then have a complete seal so as to prevent this breath from coming up. So you also know about various other side effects, like patients of asthma or already those having breathing problems have increased respiratory resistance because of the use of the face mask. Patients have a lot of itchiness, ocular discomfort. So to conclude, prolonged regular daily use of face mask could harm the ocular surface, not only in patients having dry eye disorders, but also in normal eyes. And this could cause worsening of several clinical and molecular parameters. This can have a negative impact on the patient's quality of life, especially because now mask is something that is now here to stay. Increase of inflammation has been the main underlying molecular mechanism, and we need to look at this very seriously with modification of environmental factors and modulation of drug strategies, including higher treatments like the IPL. So to conclude, take-home messages, we need to be more alert as physicians to be aware in the OPD, especially in the high-risk category, especially those who are more at exposure to digital devices. In refractive surgery and cataract surgery patients, we have made it a part of a routine workup to do a dry eye workup, counsel these patients well, especially the refractive surgery and the cataract surgery patients, detect, especially those who are going in for premium surgery, premium IOLs like multifocals and torics, detect early, treat early, and monitor these patients regularly. More than anything, never stop learning, because life never stops teaching. Even today, as a crisis drives us apart, we heal by coming together. Thank you so much for your kind attention. Thank you.
Thank you, ma'am. Thank you very much. This is a wonderful presentation. I think we all of us have faced a lot of problems, what she has mentioned. Especially it was very, very surprising to see a very threatening complication of mist on the during LASIK as well as on the IOL. I mean, they are very, very dangerous to see. It's very unheard of, especially the COVID part. Now, just one or two questions so that we can quickly go to the other talk. And of course, the other panelists can also ask questions. See, the first part is that taping of the mask. Now, a lot of OPD patients, I'm talking about OPD patients, come with different types of masks, like, Wildcraft mask. There are a lot of space between the nose. We can't do the taping. Maybe we have to apply the bandage, in fact, so to prevent the fog. So how do you handle those cases? And that's one thing. And in the OT part, two areas, OPD and OT part, how to make our life better as a clinician.
Sir, I feel taping of the mask is the best way to go. The one reason is because no matter what mask they wear, whether it's a cloth mask or a surgical 3-ply or even the N95, most of them have a space between the mask and the skin. So unless and until we actually stop the exhaled air from coming onto the surface of the eye, we will continue to have increased dry eye, we'll continue to have fogging of glasses, not only spectacles, but also during refraction, during perimetry, and more importantly in LASIK. Like, for example, the complication that I had, we had actually already taped it, but it got loosened. And because of the, it gets loosened, there's still very good scope for the exhaled breath to come onto the surface. So in fact, towards the end, we removed the mask. After we put the drape, we removed the mask so that at least the breath can go from down instead of coming up. What happens is the mask fits well down, but not on the upper part. So the breath can escape only above, not below. That becomes a problem. And during the OT, like I said, many patients find it very suffocating with the N95 in cataract surgery, especially the older age groups. So then in those patients, we use a 3-ply so that there is more place on the lower part or an inferior part for the breath to escape. But at least we tape the mask on the upper part so that it doesn't come up. In fact, even simple things like doing 90D examination. If you have a patient who is using a mask and you're putting a 90D, by the time you're actually focusing, the 90D lens gets fogged. So many times either you keep cleaning your 90D or you ask the patient to remove the mask, which becomes a bigger risk to you. So these are the practical problems that all of us are facing.
Yeah, 90-day problem, I would say I have solved it.
Yeah.
You have a wonderful cap of a Dettol or bottle. You put that 90-day, it fits well. So it has got an extra lens so that fog doesn't appear. I mean, I can share the video. That is one. Second, many times you always wear the gloves. You touch the mask corner with your one finger so that the breath don't come through that area. Then you hold that 90-day. I mean, that is one more thing. I mean, of course, other panelists can also add on to some tips in this.
The same thing I did it for femto LASIK patients. The moment now I'm actually aware and I'm looking for that wave of the breath. So
Yeah.
I press on the patient's nose and I tell them that you hold your breath for 30
Yeah,
seconds.
sometimes, yes.
Sometimes I need to tell them, if not anything, because I don't want again an interruption of the femtosecond delivery.
True.
Yeah.
True.
I before I asked you a question, I wore my mask. So when we are doing refraction, I always tell my optometrist, once the patient has closed one eye, they keep one index finger over here, and when they put the finger here, the glasses which they are putting, they don't get fogged.
Yeah.
So this is one just simple way, and just like Shailesh was saying, when you're doing 90D, you keep one finger over here, and then you hold the lens, so it becomes easy. But all the patients in my OPD also, I tell them, keep your index finger here, and then close your eye, and then do like this. So it helps in.
So actually, what we realized was that before the COVID came in, we were using the 3M masks. The 3M masks were probably better because they have that aluminium, the aluminium on the top, the nose piece. It is much stronger and it is more deformable. Unfortunately, what has happened is that all the other, now even the 3M masks have gone down, but the initial supplies, they would not really fog as much as, you know, the ubiquitous supplies are fogging. So I think everything is to do with the way the nose piece, if the nose piece is on the outside of the mask and it is, it is an aluminium nose piece, with a then you can actually give it the shape that you want, and then of course you tape it up, it works.
No.
But like even that tape will give way after some time.
Yeah, correct. Many times they remove it for water drinking or some other issues, so it's very difficult. It's a very challenging situation. Now, next, move on to the next speaker, and the topic is very interesting: posterior polar cataract. The lessons that we learn, we keep on learning on posterior polar. It is an endless journey, and who other than Dr. Satyajit Sinha who can speak on this posterior polar cataract? Please go ahead, sir. He is a wonderful surgeon. He will teach us some lessons on this. We are eagerly waiting for it.
Thank you, Dr. Shailesh. Can you see my video and can you hear my voice?
Yeah, very clear, sir.
Okay. So thank you very much. I would like to thank Dr. Ellen and the entire COSCON committee for giving me this opportunity to speak today on posterior polar cataract. This person happened to be a politician, a young MLA from Bihar Assembly, and he was having problem in his day vision. And he wanted a premium lens because he was very young. He said, I want the best lens available. And my heart was in my mouth, wondering that this is the posterior polar cataract and he wants the best. But still we went ahead, and I wanted to show some lessons that we have learned in this case, especially all our young friends who are watching this webinar, this conference. I wanted to share my experiences in this case. So you have to be very careful right from the beginning of all the incisions that you are making and the ports that you are making, because chamber stability is very important in posterior polar cataract, right? Especially in the end. I'll just. Shailesh, can I come back after the next speaker? I think they gave me the wrong video.
Okay, Shailesh, you're muted.
Okay, sir. Okay. Now, I would like to call upon Dr. Bibhuti Sinha. His sir is there.
Vibhuti is not there. He has gone to take exam.
He is not logged in also, I think, right?
Oh, yeah,
I don't see his name there.
Okay, now next is our own Dr. Jatinder Bali, sir. So, are you ready, sir?
I'm ready.
Yeah, sure. Good, good. Great, sir. Thank you. Thank you. So sir will going to speak on a wonderful topic, that is how to read results in papers. Of course, not in newspapers. When to change existing practices in practice. It is a very interesting topic. We all should know. So the sir is going to talk on this interesting topic. Over to you, sir.
Thank you so much, Dr. Shailesh. Nice to see you without a mustache. I want to thank
it is mask
the
related, sir, to
COSCON.
enhance mask fitting.
I would like to thank Dr. Elan, the Karnataka Ophthalmology Society, the COSCON, for giving me this opportunity to talk to you about how to read results in papers and when to change the existing practice. This presentation is dedicated to one of my seniors whom we've lost very recently, the People's General from my alma mater in Simla. Oh. And so far as financial disclosures are concerned, I'm the author of a book on biostatistics for the medical practitioners. This book covers everything that any medical practitioner is going to use in his entire service career. Now, whenever we read papers or articles, the first thing that actually crosses our mind is it really going to affect the way I practice? So to answer that question, there are basically just four pillars that we need to look at. One is, what exactly is it that the paper is saying, the results? What is, how good or how bad is that set of papers? Is this, the findings that are there, are they generalizable to other populations? And is your population actually similar to the population in which these studies had been carried out? Now, one by one, I'll just highlight the salient features of how we should go about it. Now, we are analog people. We like, our cognitive learning is based on words. So, if I were to throw these three statements at you, 3 deaths less than the other group, 75% reduction in mortality, or 300% or threefold increase in mortality compared to the other group, I think everybody would say that, they don't want to go with this one. They would much rather go with these two. But look at this. This is the data. So it is 3 deaths less than, this is 3 deaths less than this. 3 out of 4 is 75%. So that's a reduction there. And if you look at the other way around, it's a 300% increase. So the way it has been worded is now really going to change the way we will react to it. So our basic methodology, which most of us follow, would be, read the abstract, go to the conclusions, come back, read the discussion, read a bit of materials and methods. And, very few of us would really go into the results part of it. So that's why, words can lie, but figures are never going to lie. So we should look at the figures, and I mean the figures down here, right? So the purpose of any study is to find out some truth which is there in the universe. To do that, what we are doing is basically taking a small part of that population that we have, which we call the sample, and we are making some measurements in it, using some sort of a study plan. And these findings give us, some values, which is the truth, which is present in that study. Now, from that truth, which we have in the study, we want to find out and extrapolate it to the truth that is in the population using some inferential statistics. So what is important to understand is that there is a methodology which is involved, and therefore all steps should have been followed in that methodology if we are going to commit our actions to the findings of such a study. The first thing to remember is that whenever something has been measured, the variable can be either qualitative or quantitative. Now, qualitative can be on the basis of names, east, west, north, south, male, female, or it could follow an order, mild, moderate, severe. Or it could be quantitative, that is, it could have discrete numbers, taking whole integer values, number of deaths, number of births. You cannot have half a birth, you cannot have half a death. So there would be certain things that you can do with those and certain things that you cannot. And then you have those continuous variables, which you can, which can be 1.45, which run into decimals. Now, why that is important is because there would be certain tests and certain things which would be available to you. For example, for qualitative data, you'd be using counts, frequencies, and percentages. And some of the tests would not really be applicable which are available to you for quantitative data. Whenever you have quantitative data, you need to describe the data, because you see, the data has a particular shape. You don't want to compare apples to oranges or oranges to bananas. So whenever you want to describe your data, first thing you want to look at is, one value which represents this entire data set that I have. So you will give me, you remember CSSD, the sterile supply stores. So something like that, it is here. First thing you do is look at the central value, which could be the mean, the median, the mode. Then how far from the center, the extreme values are extending. Then look at what kind of a distribution this particular data set has. There could be, more values on one side of the mean, or they could be on the opposite side of the mean. So this is called skewness. Your data is skewed to one side or the other side. So you are going to compare similarly skewed data sets only. Or all values could be, closely bunched up together in the center, rather than, you could also have a situation, this is called leptokurtosis. Or they could be, lot of values at the sides, lot of values here. This is a platykurtic curve. This shows that there are more values here and here. So I now really need to use different sort of parameters when I'm going to use those cutoffs. So now what have we actually seen? We have picked up one central tendency. We have seen how far from the central figure, the central value, the values are dispersed. That's dispersion. Then we've looked at, the shape, the symmetry, the skewness. And now what we want to look at is, are there any deformities, or are there any outliers? For example, you have 1, 2, 3, 4, and you have a value which is 200. So that 200 is an outlier. So what you need to do is, if the outlier is there, you either need to go back and check why the outlier came into your data set, or you need to, if the data that has already been explained, then what you need to do is, instead of mean, you go ahead and use median, so that your calculations and your decisions are not impacted by that extreme data set. So what we have now discussed is that, there are different type of variables, and each variable will have a different type of best measure of central tendency. Now you have described the data. My favorite, when you have a large number of studies that you want to compare, my favorite is the box plot. In a box plot, there is this line which will show you the median. This line, which is the upper quartile, shows that 75% of values are below this. This line, which is the lower quartile, is showing that 25% of the values are below this. This to this is the interquartile range. And from the upper to the most extreme value, and from the lower to the most extreme value, there are these whiskers which are running, and they show us where the lowest data point is situated. Now, if you have 5 studies, they are stacked up one against the other, you can visually see how each study is comparing one against the other. Now, all data sets are not going to be similar. There are different type of distributions that exist. For the purpose of the present discussion, we will just look at, whether it follows a normal curve or it does not follow a normal curve. Best way to do it is, do a histogram that is never going to be described. So there will be some goodness of fit test, Kolmogorov, Smirnov, something will be there. So see whether it is parametric, non-parametric, whether it follows the normal curve. If it follows the normal curve, you'll be using parametric tests. So he will have used some tests. Just ensure that, the correct test has been used for the correct situation. Now, you also need to evaluate how good or how bad is the evidence that you are collecting. So there is this there is this thing called the hierarchy of evidence. The best, of course, is if you have, a Cochrane review answering that question, or a meta-analysis. Below that, you have the systematic reviews, the randomized controlled trials, and at the bottom of the pyramid somewhere, you have these case control studies and case reports. So whenever you are looking at it, you have to look at, first thing you want to see is, what are those factors which are related to the study in question. You find out the hierarchy of evidence, which is the highest possible you can get for answering that evidence, that clinical question that you have. And then those should be the best results that should be available. The results that are there, they should be valid, they should be plausible. biologically implausible things are, we used to say that, if you diagnose common things, you'll be commonly correct. Now, the wake up call is, it is not very, very fast that, the research comes into our medical practice very quickly. It takes between 6 years to 25 years, and the average is around 17 years. I will give you the example of the Antman study on the myocardial infarction treatment. We already knew aspirin use in 1966, but when did it become mainline? Was in 1992. It was the complete series of meta-analysis. In this, the fastest has been 6 years. In ophthalmology, we have been relatively fast in adopting these things. Now, what do you need to answer in terms of, see, there are internal validations which we need to really look at. You need to see whether your clinical setting is similar to the study, your healthcare system will allow it, the expert opinion and the regulations, which are usually going to be conservative. And whenever you are evaluating the studies, always place a randomized, wherever randomization has been done on patients, place it higher. If patients are not lost to follow up, place it higher. If patients are not shifting from one group to the other in analysis, place it higher. If blinding has been done of patients, healthcare providers, and the subjects, place it higher. The groups who are comparable at baseline and same treatment or same interventions have been utilized and nothing else has changed, then place those studies higher. And if data is missing, whatever, you start discounting it using, there is an serial index method which is there. Also, please remember that the entire spectrum of the disease should have been covered, and whatever utilities that we are talking of are valid, they are utilizable, they are accessible to you in your practice. And always remember that, you see, at the end of the day, there are regulations, there are guidelines that may still constrain us to incorporate it using professional bodies, and let it come through the guideline route. When you read a report, you can only assess the internal and external validity and the originality of the paper, or whether the ethics clearance has been taken. You cannot really assess protocol violations, will not be mentioned. What was the quality of record keeping, the study procedures, the degree to which it actually is giving us the data, and the falsification and fabrication. So just 4 parameters. First, understand what the study is saying. 2, what is the quality of the study. 3, generalizability of the findings of that study to other populations. And 4, generalizability of those findings to your population. And last but not the least, always remember that there are regulations which are in place, so you should not go wrong of the law. I think I come to the end of my presentation. Thank you so much. If anybody has any questions.
Oh, thank you, sir. Thank you, Dr. Jitendra, sir. It's a wonderful presentation. In fact, all PGs and of course all practitioners also should know, because the PGs, more important is they have to conduct the study. Before that, they should know how to do it, and they should understand also. I remember as a PG at RP Center, we used to go to DOS library. We used to have articles to DOS Times. There it was just writing the article without any statistical correlation. Now it has come as a DJO, and nowadays you people are doing wonderful job at DOS library, giving articles free of cost also on request. That's hats off to you people. Now, sir, one more thing I want to know. In a busy practice, I mean, like, how do you conduct a study for a practitioner? Tips like, maybe because they keep on giving the excuse, I don't get time. But
sir, I think the most important thing to understand is, see, in the last 70 years, we've not won a Nobel Prize in medicine. We've not done any path-breaking research in medicine. The problem, I think, lies in the fact that we are, empowering the students to do the research, and we are neglecting the practitioners. You see, the practitioner who has an insight into the disease process, into the system, all the ideas, bright ideas, are going to come from people who are using it. The difference between us and Japan is that, Japan harnesses the wisdom of people who are working within that system. So that is what we are doing in DOS. So we are coming up with with the independent ethics committee, and we are also planning to initiate a series of workshops where we would like, you know, collaborative research between different work centers. And we want, basically, so there's a very large study called veteran study. What they realized was that one person did, you know, a humongous data set, 51% of people, and they got the answer on wrong on who the next president would be. On the other hand, there were these veteran associations that were there, so they took, you know, small interviews of you know 25, 30, 40 people, but from diverse locations. They got the answer right. So this is you know, small data sets from different locations and localities will give us greater truth of the population. And we are actually working on it in terms of policy framework also. Let's see what comes out of it. I hope, you know, societies like Dr. Sena is here, Dr. Sabyasachi is here, and Dr. Elan Kumaram are here. I think what we really need to look at is the confluence of efforts, because we have to empower the practitioners to conduct that research, sir.
True, sir. True. Well said. Basically, what software you would like to advise to start with, like, you know, SPSS softwares we use, which is easily available, and any help that's available, like instantly, if someone PG or some practitioner wants some tips as of now.
So today you can do it in Excel, you can do it in SPSS, you can do it in Stata, you can do it in R. The problem of the tools has disappeared. The tools are available aplenty. And basically what is most important, see, it is the quality of data. Why we are saying that the practitioners have to be involved, the practitioners have to be involved in a very big way, is because the practitioner knows the impact of what he's writing on that sheet. You see, what is happening in most of the retrospective studies that we are getting in hospitals is somebody has written that data sheet, has written the case sheet. And the quality is like, you know, you have very good recording and you have very poor recording. It is not, there is no consistency in the quality of data. When the practitioner writes it, it is absolutely same consistency. जो आपने पहले लिखी है, वही आपकी आखिरी है. मतलब we know, we can place it. Okay, you know, this is the amount of bias, or this is the amount of, you know, in institutions we have these random effects that are taking place. So I think what we need to really talk of is people should be planning their studies. They should be discussing their studies. You know, the plans should be discussed rather than what happens is we finish the study and we discuss it. We should be discussing plans. We should be
like a protocol.
Protocols we should be discussing.
Exactly. That is to be discussed and threadbare, and then carry on the study. Any other tips from the other panelists, please?
I just wanted to ask Dr. Jatinder Bali.
I have a comment, just 1 minute, 1 second.
For so many years, from the time of Dr. Natarajan to Dr. B.K. Nayak, Dr. Sabyasachi Sengupta, so many people have been working on trying to motivate and an entire generation has passed off in the last 20 years. But like you said, we haven't won a Nobel Prize, leave alone Nobel Prize. Some real kind of a research work has not come out of India. And our publications are also more like a re-research kind of a thing. We just do the effects of what has already been done in the West. Where do you think is the missing link? Where are we missing the boat? Why are we not able to come out with more original articles rather than doing re-research?
Sir, all the great ideas are going to come from the fringe. What is happening is we have this system of entitlement. We have allowed only some research institutions to take. We have allowed, you know, a handful of research institutions to commandeer, you know, the idea platform. Unfortunately, what has happened is it's the students in those institutions who are doing the work. So if a consultant says, okay, you know, this, in fact, they've got this term for it, rationalize the results. That brings a smile to Dr. Sinha's face. See, I was actually shocked when I was, guiding. I was the member secretary of ethics committee, and I was told, you do this, you do this, and then there's rationalization of results. I said, what is this? And the funny thing is, the student was quite convinced that this was a valid step. Now, you understand what is happening. That student has to take an exam. He has to take a degree. If I tell Satyajit Sinha to falsify the data, Satyajit Sinha is not going to falsify the data. He has a reputation riding on it, right? So I have to get the incorruptible people to, one, report what they see and do what they say. That is all. What we have to focus on is research integrity. Research integrity will come in only when you have, mid and high rung practitioners devoting, like giving their time and publishing their paper.
But for a simple practitioner, you need an ethics committee even to write an article in a journal. And
Exactly,
to make
sir. We have
ethics committee for a common practitioner is very difficult.
Sir, that's exactly what we've done. We realized that there was a problem. People were going to some of these institutions and they were told that you have to add one person. Hamara ek aadmi. I think wrong place to actually be discussing this, but that has happened with a few people. And now what we've done in DOS is we've already got like an independent ethics committee approved for DOS. And I think we have all the thought leaders here. We've got Dr. Shailesh, and we've in fact Dr. Anagha is also here. No, she's left. Dr. Srinivas is here. And you are here. So I think what we are making a template in Delhi, and we'll be more than willing to share that template. We will be more than willing to lobby in policy changes. And we've all seen, you see, Dr. Nayak's efforts. He has created a generation of researchers. All of them are doing, things in their own sweet way. They are not coming together. I think, some community kind of a participation has to be created somewhere. I don't know how to do it. I really don't know.
Dr. Sabyasachi, sir, you wanted to tell something?
Yes, sir, sorry.
I have just one comment on this thing, because many people are writing and publishing in journals, and they are also gets published. Now the thing is, the editorial board should have a team, something, who will go into the statistics and other things, whether this is applied properly or not. So that the end, because all the doctors, we cannot expect that all the ophthalmologists should know all these statistical things and it is being properly used in that or not. But ultimately, we will believe on the conclusion, what the conclusion of the study is. So it is the responsibility of the editorial board or the team to have some members there to go into the statistics part, so that once it is published, then we'll take it that mostly the statistical part has already been properly taken care of. This is my comment.
Sir, can I come in, sir?
Yes, sir.
So you're using biometry, you're using corneal topography, you're using visual fields.
No, that is correct, because the thing that you described, parametric and non-parametric, this data, then the tests applicable for that. So these things have to be before a paper is.
Sir, I'll be sharing those. I'll be more than willing to share those, sir.
No.
So what I'm saying is, sir, the only thing is.
No, your topic, our topic was discussion was how to take it for our own. I mean, our situation, whether we will take it or not, the conclusion.
Sir, it is not difficult at all. All I was trying to say was that you're using very advanced statistical techniques already, sir.
So
you're using advanced statistical techniques.
Many papers also we see that those who have, all of those of us who know a little bit about statistics, it is not properly tested.
So we'll be having workshops.
But still it gets published. No, my concern is how is that article is getting published?
Yeah.
Okay,
how it is getting published when this thing is. Sir,
Yes.
actually, there was a very nice study that they did. And
Yes, I have also seen that study. Because now my advice is, or suggestion is, at least for the good journals, the editorial board should have a team to go into that and reject at that point of time or advise that no, proper statistics is not used. You modify it and resubmit.
Sir, actually, the board, this thing is supposed to do it. The journal is supposed to do it.
Yes, that is what my point is.
Yeah.
Once it is published, 90% of the people take it that the conclusion is valid.
True.
Yeah. Now, just
You analyze whether it is right or not.
meanwhile, when Dr. Satyajit Sinha will be preparing, just last 1 or 2 words, Dr. Jatindra sir has nicely told, there are a lot of hidden talents who are away from the big institutes or the named institutes, just like our Padma Shri, Padam Bhushman awards being granted to so many wonderful deserving candidates who were missed so many years. They have done great work and it was recognized. Same thing for us also. We have to recognize a lot of people, a lot of talents in the smaller places or smaller institutes. But only thing is we have to guide them and we should tell them to recognize their talents, and we have to help them in many ways. Like you are doing, so many societies should get together and enable them to come out with good research and publish them. So with that, I will just start with Dr. Sinha sir's talk, sir. Please carry on, sir.
So, yeah.
Thank you, Dr. Shailesh. Thank you for re-accommodating me. So we were talking about the posterior polar case in which I said he was a young politician. He wanted the best premium IUL and he had posterior polar cataract. So I said, well, we are making incisions. We have to be very careful that even in the beginning, we have to make these ports very carefully because the chamber stability is very important in these posterior polar cataracts. When we are making the rhexis, we have to be extremely careful. You don't want the rhexis to run out because there's higher elasticity in these young anterior capsules. So you have to be extremely careful. You don't want to make it too small because when you are doing a hydrodelineation, there may be some fluid rushing and putting pressure on your posterior capsule. So you want to be very careful when you are making the rhexis. Once you have made the rhexis, you are comfortable. You do multiple ports for go inside and do multiple at times hydrodelineation so that you make different layers and it makes life a little easy. Now, we are initiating this. You don't ever rotate the nucleus in this, and especially after you have done hydrodelineation, you will find it rather simple to move this the nucleus part which you have hydrodelineated, and if you have made the rhexis of adequate size, then it is easy to just get the whole moon crater into your phacoemulsification probe. Before you are coming out, you must put in viscoelastic because you don't want to put stress on the place where the posterior polar cataract is. This is one point which has to be mantra which has to be remembered. When you make a side port, now comes the difficult part because you have done hydrodelineation. The cortex is thick and it is attached to the posterior capsule. You don't want to pull out the whole posterior capsule at one time, the whole cortex at one time. You don't want to put stress. So you pull the cortex, you do the irrigation aspiration in small parts and try to bring all the cortex to the center. You try to preserve the posterior polar part where the posterior polar is attached right till the end, until when you have detached all the cortex from the capsule. And in the end, once you have done all that, and if you are gentle in your procedure, slowly the posterior capsular part which is also there gets detached, and then it becomes easy to aspirate all the cortex which is there. As you can see in this case, and you have to be absolutely very careful with each step that you are doing because you don't want any chamber fluctuation. Once you have done that, whatever little cortex is remaining on the posterior capsule, don't try to rub and clean at that point of time. Like you see over here, these cortical matter which is remaining over here, don't put it. Once you have put in the IUL, then you can polish the posterior capsule. Now here we are putting a premium IUL. At this point, it appears that it is going in the bag, while if you see careful, you will realize that the IUL is going towards the sulcus. You want to be very careful in these maneuvers that when you are putting these IULs, you don't want to put stress on the posterior, where the posterior polar part was, so that it doesn't tear. So once you have put everything in place, you gently snug in the IUL into the bag, and it helps also in without putting too much pressure. Once you have done that, then because there have been many instances where you have finished the posterior polar case, you are most relaxed and you think the case is over, and suddenly there is a tear in the end. In these premium IOLs, it's very important that you clean all the viscoelastic from behind. So while you're cleaning all the viscoelastic from behind, it is also important that you clean all the remnant cortex which is there at the back of the IOL and not in the beginning. So these are some of the pearls that I wanted to share, and thank you for the opportunity.
Thank you, sir. It was a very nice presentation.
Beautiful, sir. Beautiful.
Yeah, wonderful. Now, just I want to highlight
Thank you
three
so much.
points. I would like to welcome Dr. Ravindranath also, who also is a very fabulous cataract surgeon, to add on to some tips. Now, sir, deciding on the rhexis part, see, if you do a bigger rhexis, it is helpful to prolapse the nucleus and get things faster. But at the same time, when you have a PC rent or something, so it will be difficult to put the IOL. So what is the optimal rhexis size in these cases?
You're asking my professor,
You,
Dr.
sir,
H.M. Ravindranath, or you're asking me?
Speaker, sir. Sinha, sir.
Okay. So I optimally try to keep it at 5.5 millimeters, so that what I showed, it's easy for me to get the nucleus out as a crater of the whole moon. But there are some people who propagate that a smaller rhexis in a posterior polar cataract may be more helpful if some untoward incident happens.
Yeah.
So, but I have been generally making a 5.5, and I have been okay with it.
Yeah, often these patients are younger ones. Now, pre-operatively, are there any very sure shot investigative methods where we can find out that there is a PC defect, so that we can decide on the multifocal IOLs or the premium IOLs, so the expectation of the patients can be reduced at times? Like,
Absolutely, there are several studies, and there are several OCT studies of these posterior capsules. Now you can use these anterior segment OCTs and see if there is a capsular defect and prepare the patient from before itself. Maybe if you see a posterior capsule defect in the OCT, then you can tell the patient not to go in for premium IOLs.
yeah.
But there are several studies on these OCT, and we also regularly do these OCTs before doing posterior capsular cataracts.
How do they match with your on-table results?
So once you see a posterior capsular defect, then obviously you are extremely careful with it, and you don't tell the patient for premium IOLs.
Yeah, true. Counseling becomes very easier.
Very easy.
Dr. Ravi, any other tips, or any other panelists, any tips on posterior polar cataract?
I think is covered well. Planning a posterior capsule starts with counseling, and there is a very possibility of second procedure should be told to the patient before. Sometimes you may end up in nuclear collapse. But over the time, the management of posterior polar cataracts have been better and better with the understanding of pathology and better microscopes, better hydro understanding of the machines. Yes, regarding the rhexis, one thing some people do oval rhexis instead of round rhexis. That is one modification. Some people intentionally do it, but doing adequate rhexis is enough. You don't have to make a smaller or bigger. It doesn't have any advantages.
I know an ophthalmologist who won a case in a posterior polar cataract after the patient filed a case. I mean, just because that doctor had written on the prescription sheet on his very first day on the OPD sheet, chances of posterior capsule rupture has been explained to the patient. So this was written over there, and this was many years back, but that saved the doctor.
Yes, correct.
In the court of law.
Correct.
No, that is correct. But for the surgeon, you should have plan B ready for every step in these particular cases, because ultimately the patient is interested for his vision. So for any experienced surgeon, you have to have plan B ready, starting from capsular rhexis till the completion of the surgery.
Absolutely, yes.
Definitely, what we have is in these cases, mostly they are posterior subcapsular. That we think to be the posterior polar cataract. So that's why we have to be prepared for any eventuality.
True. So any other, if there are no other doubts or the clarifications, we will just go on to the next speaker. Is Dr. Vibhuti Sinha logged in? I don't see him again.
He has gone to take exam in Bettiah.
Oh, okay. Now another talk will be on Dr. Parikshit Gogate. Is there? Sir, is there?
He's not there, sir.
We can go to Sabyasachi, sir.
Yeah,
then.
yes, sir.
Sabyasachi sir is
Sabyasachi
here, yeah.
Please go ahead with your talk, sir. We are very eagerly waiting for the talk. Sir will be speaking on teleophthalmology, the way for universal care. It's a very interesting topic, which
Wow,
we are.
sir, that's a nice topic, sir.
Yeah.
I'll be talking totally on a non-conventional.
Not unconventional. COVID has made it very relevant. This
So
topic.
no, yes, because I thank Coscom for giving me this opportunity. And the theme is for this session is my lesson for the year. But I think perhaps the lesson for my entire career in ophthalmology is this thing. The teleophthalmology is the way for universal eye care. Why I say so? Because now after 30 years of doing ophthalmology, also we are seeing these things every day. Every day we see diabetics, they do not know that these things are going on inside their eyes. And they come when they lose their sight. Advanced glaucoma, one eye lost. And also this phacomorphic glaucoma or lens-induced glaucoma. So these are the situations that we encounter, almost I encounter every day in my practice. So now again, COVID also put a situation where the people stopped coming to us and we also got scared to come nearer to the patient. So the solution, WHO also recommends that universal eye health care. So that was propagated from 2014 to 2019, so that all people should enjoy access to the best quality eye care without the risk that paying for such care will impoverish them. So they should afford good quality eye care, everybody. And now the theme by WHO is integrated people-centered eye care. So what it is all about. Now, till now, we have concentrated morely on disease-centered eye care. Patient having cataract will come to us, or patient having glaucoma or some problem is coming to us, and we are thinking about the disease, how to get out of that. Now that is to be changed to the people-centered eye care. What is that? The services that are merged and delivered so that people receive a continuum of health intervention covering promotion, prevention, treatment, and rehabilitation facility. So it recognizes people as the participant and beneficiaries of these services throughout their life course. So once a person comes to a primary healthcare center or primary eye care center and something is detected in his eyes that will lead to some problem, then the system has to take care of him, where should he go, what type of treatment he will receive, and ultimately what will happen to him. So that is to be done by the system itself. So there is importance of regular eye examinations, then availability of services, and integrated and effective referral pathways has to be there. It is not that you tell the patient, you go at this place or that place. That is not proper referral. Actually, referral is, there has to be two-way referral. We will send it to one institution and we will get back the feedback from that institution, what happened to that person or that. Now, what are the challenges? We have 12 million blind people against 39 globally. So India is home to at least 1/3 of the world's blind population. The prevalence of blindness is higher in lower socioeconomic groups. 80% of the blindness, as you know, is preventable by timely and quality eye care service. So, but the thing is, India has one ophthalmologist for every 1 lakh population. And there are only 45,000 optometrists against a requirement of 1,25,000. 72% of the population live in rural areas, where 70% of our doctors, they practice in urban areas. So there is a big mismatch between the availability of the services and the people who are waiting for these services. And what we have found out in COVID is there was drop of 81% case volume in ophthalmology OPDs. And that is the largest drop in cases as a result of COVID of all specialty studies. So this is the situation. In Southeast Asia, we have 9 ophthalmologists per million population. So what is the solution for this? Naturally, teleophthalmology is the solution in which ophthalmology can be practiced remotely by using telecommunication to exchange medical information and images. So teleconsultation can decrease burden on the current healthcare system, and only by using teleophthalmology, early detection of sight-threatening conditions are possible. like diabetic retinopathy screening, AMD screening, ROP screening. These are all successful models, teleophthalmology models, which implemented or replicated throughout the country to prevent blindness. So Government of India also during this COVID time passed this telemedicine practice guidelines and also give legal status to teleophthalmology practice. So all of us have to be conversant with the provisions that are there in these guidelines. And there is a provision that we have to be trained within 3 years from implementation of these guidelines. So there are 7 steps, elements. We have to decide the context, in which context we are doing teleconsultation. Identification of the patient and the practitioner is very important. Mode of communication, the consultant has to decide whether it is a text mode or audio mode or a video mode. We have to take the consent of the patient. If the patient has called for this, is implied consent. If you are using any other method, then that consent has to be also recorded. Types of consultation also to be decided by the physician or the ophthalmologist, whether video consultation is required or physical consultation is required, basing on the complaints and the basic examination. Then patient evaluation and patient management. There are also certain guidelines to be followed. So we can have real time in which direct video consultation is possible or has to be done, or asynchronous, that is store and forward model. So these are the models in which teleophthalmology can be practiced. So we have to maintain proper documentation. This is as like a physical consultation. Whatever is to be done, that is to be properly done for medical legal purposes. Then Government of India has a portal, eSanjeevani portal, and also encouraging to use teleconsultation for different medical problems. So we have to find out how ophthalmology can be properly incorporated in this eSanjeevani system so that you can reach to majority of the population. Now we have founded Teleophthalmology Society of India during this COVID period to formulate guidelines. Then we have started online training program through Eco India. Then we are planning for teleophthalmology models for every practitioners as per their need, and how to procure proper equipments. So we have industrial members who have also agreed to participate and to help us in this manner. We are also preparing softwares to be used by all at affordable cost. Then video platform, there are mobile apps, we are also working on that. And also we are planning to handle all legal issues through this society. Then how to set up? We have to have a plan. Ask yourself, what do you want to accomplish with telemedicine? You have to be very, very sure what we want to do and what is required. Then decide how you will use telemedicine. Start with few services. Don't think that you will provide all these services at one go. That is very difficult. So start with few services, then expand that. Make sure patients are aware that you are offering telemedicine services. So different services can be planned like this. Home OPD services can be done where you can triage your new patients. Pre-operative planning and counseling can be done through telemedicine or teleophthalmology platform. Follow-up also you can do post-op cases and other chronic cases through tele mode. Then you can establish e-vision center. That is a facilitator based. We will have an ophthalmic assistant and optometrist in vision center and can connect with you through telesystem, and you can give proper advice to the patients who are there. Then mobile teleophthalmology camp can be also conducted, comprehensive camp or diabetic retinopathy, glaucoma, cataract camps. And there are also AI-based apps that can be used for this purpose. Then online cross consultation or second opinion from experts on connection to tertiary eye care centers is also one component of the teleophthalmology. So these are the conditions which can be tackled or which can be advised properly by teleconsultation method. Subconjunctival hemorrhage, then echalagium, this hypermature cataract, pterygium, these things. But when there is pain, diminution of vision, severe photophobia, and in case of doubt, it is better to have a physical consultation and advise the patient properly rather than going in for teleconsultation. So we have to again decide proper equipments. Dual screen LCD monitor is required for this purpose, in which you can enter in a EMR record in one, and also video consultation with the other monitor. You have to have good camera and microphone. Internet connectivity has to be fiber optic, not mobile internet services. because that is not proper for teleconsultation purpose. To choose proper telemedicine software or app for this purpose. Then set up your space. It is like you have to select a quiet room so that the patient will have confidence on your consultation. You will feel that you are attentive to his problem, and also you will feel as if you are doing a physical consultation. So there are certain etiquettes. Dress up properly as if you are doing a physical consultation inside your clinic. Be punctual for tele appointments. Develop a good website manner with telemedicine patients. Be inviting. Not so often when patients are speaking, so that the patient will feel that you are responding. You have to look at the camera, not at the screen. Ask questions to encourage them to open up. Maintain eye contact with the patients. Then when looking away to consult the record or write orders, let them know that you are deviated. Then also there are a little bit of patient preparation which your support staff can advise your patients how to sit, how to use what type of lighting for that purpose, so that you can have a good teleconsultation. There are also different apps also can be used for this purpose. So basically every secondary eye care system has to take the burden of connecting to primary eye care centers, what I call is a e-vision center with a teleconsultation facilities. And the secondary eye care also should be connected with any tertiary eye care center. So for cross-reference or for any advice for the patient. So to conclude, teleophthalmology can be an effective and feasible model for providing universal eye care and prevention of blindness. There is need to develop standardized teleophthalmology solutions and comprehensive, economical and user-friendly SOPs. Public awareness and orientation has to be there for its acceptability. So there has to be a paradigm shift for ophthalmologists, a whole different way of thinking about ophthalmic care that people are not used to. So my suggestion is let us all get started so that ultimately this will be a part of our day-to-day activities and will serve the entire population of the country. So thank you very much.
Thank you, sir. Thank you, Dr. Sabyasachi, sir, for the wonderful presentation. I mean, being a governing council member of the Teleophthalmology Society, you are given a wonderful tips, especially on the etiquettes, like you should be dressed as a doctor, not that you are sitting at a home and then speaking out. So we had also patients' feedback from our hospital also. We thought of for the first lockdown, 3 months total shutdown, how to reach out to the patients. Then the government also started opening up. We also made an app so the patient starts responding. We started reaching out to the patients, and so patient felt very happy that they are connecting. The hospital is connecting. Otherwise, they all left high and dry. Where to go? What to do? Just a simple word or just show their eyes once, and then it's okay. You can wait or you can come. It helps a lot. So technology has helped us a lot. Of course, it's a double-edged sword sometimes, but it's a wonderful presentation, sir. Any other tips from the other speakers?
LV Prasad has also very good experience of using tele model during this COVID time. I think we can highlight a little bit on that.
Yeah.
Actually, what I think we missed out on a few things. The government, you see, the government came out with slightly, it just allowed us the permission to create the framework. We did not really get a stack. What we needed basically was, like in Linux, they created a stack and everybody built upon that stack. 20 years ago, nobody would have thought that, Linux would be what it is. It was a few thousand lines of code. Today, it is 27 million lines of code. Top 500 supercomputers in the world are running on Linux. So and the point is that, you see, we did not really define the platform. Somewhere along the line, we'll have to use the mobile internet connectivity, because fiber optic in the far-flung areas, I don't know.
5G. That's why we are waiting for 5G technology. They say that will be faster, and mobile telecommunication will be also faster.
So, in terms of if we were to say that, out of the subspecialties, which would be the first one to benefit the most? Would it be,
they say the dermatology is the most relevant.
Okay. And sir, how far are we? Because see, we would need
No,
very
because
fast imaging.
ophthalmology is another preferred branch because we mostly now depend on images.
Yeah.
So
But we require high quality images.
that is correct. So store and forward model, basically hybrid model will be the best for
I think hybrid is the only model that would work. See, real
Yes,
time, I think
because some of
it
the
will be a waste of
images will
energy.
be taken up and forwarded to us, and we can interpret and directly discuss. That's why I said that dual monitor is important, is very much relevant for us. In one monitor, we'll see the images, and in the other monitor, we'll have the patient directly connected to us for our advice.
Yeah, good. So now it's one interesting discussion, sir. Let us move on to the last topic. I think there are no other speakers who have joined. So I would like to invite Dr. Smriti Rekha Priyadarshini. So she will be speaking on one more interesting topic, that is COVID diaries. We all have COVID diaries.
Yeah, that's a very interesting one.
It is digital diary, I suppose, not the bookish diary, I suppose. So over to Dr. Smriti, madam, just so that we
Sir, already recorded, sent my pre-recorded video. We run that.
Yeah, Abhinav, just please play
Yes,
recording.
doctor.
Yeah,
Yes,
please.
doctor.
Yeah, thank you, Shambhavi. Thank you.
I think if the wrong PPT, so
No, yeah, it's a wrong one.
yeah,
Shambhavi, it's not the one. It should be, I think, by what name? Dr. Smriti Rekha, I think it should be like that, right?
Okay, doctor. I'll check.
It is my COVID diaries, Dr. Smriti Rekha. Just go through that. Meanwhile, madam, if you have on your desk laptop, you can keep it ready. Maybe
okay.
no, you can play from your end if it is not. She can't trace it if it is.
Okay, sure.
Dr. Sumit Lahane is there?
No, Dr. Sumit is not there.
So I think we'll finish well in time because of the absentees.
Yeah.
No, actually, it's a busy day actually for a lot of practitioners.
Doctor, I'm sharing now.
Okay.
This one, right?
No, the other one. There are 3 videos. So the last one.
Okay.
So how is the COVID situation at your place, Dr. Smriti?
Now we are quite used to.
No, the
So,
present
No, we are waiting for the Omicron.
our OPD is bombing with like 500 patients in a day.
So no change, no diminution of OPD or no scare, much of scare?
Now it is again rebanked because this October to March is a time when actually we see a lot of patients and do good number of surgeries. So it is I think today we had a monthly meeting, faculty meeting where, yeah, I think.
Doctor, I'm sharing now.
Yeah, thank you.
Thank you, Dr. Pashupati and Kuscon for giving me this opportunity. So when life gives you lemon, most of us will prefer making a lemonade. Some of us may throw them at someone, throw them back at life, or muster up the courage and say, what else have you got? So COVID has been a very tough situation for most of us. This was the first time that the word positive gave negative vibes. There were no ideal treatment protocol, vaccination rumors were there. As far as the patient care was concerned, patients were apprehensive to come to the hospital to get the treatment done. There were doctors were also very, starting from triaging to OPD waiting halls, there was a decrease in the OPD OR and everything was in a complete mess. So mostly, according to me, quantity and quality are the 2 sides of a seesaw. Quantity here meaning the number of patients, the number of OPDs, number of ORs. So when the quantity decreases, it is the right time to focus on the quality. So cataract has been is the most common surgery done by the anterior segment surgeon. So during the lockdown, there was the progression of harder and the progression of cataract. So when the unlocking process started, we started seeing patients with a denser cataract, with a more whiter cataracts. So as far as the SICS and FECO package is concerned, a FECO package is more than the SICS. So this was a time when I personally, I pushed myself in doing harder cataracts, and there was progression of retinopathy, so was the cataract. So by doing this, I had more confidence in doing harder cataracts, and my SICS number dropped and my phaco numbers increased. So I also started doing more toric and multifocal IOLs, and we know that one multifocal IOL is almost more or less equal to 2 regular IOLs. So coming to case scenario, we had a 45-year-old female who presented with a fungal keratitis, was diagnosed as fungal keratitis. We treated her with antifungal agents, and she resolved well with a scarring with an associated cataract. We planned a triple procedure for her. This is a suction Trifine 8.5 millimeter. Partial trephination is done, and I removed 50% of the superficial stroma. Big bubble was attempted. Failed. This is a type 2 bubble, and most of my cases, manual dissection works, does the job, and about 90% of the stroma was removed by manual method. And what we are left is a posterior stroma, a thin layer of posterior stroma, and the Descemet's membrane. So this was followed by a phaco. Settings were regular settings. Adrenaline was given to inject it for dilatation, did not happen. Now this is air bubble is injected, and synecholysis was done. Followed by initiation of rhexis. Completion of the rhexis. Sorry for the decentration. Now, rotation of the nucleus. Phaco was done using was performed using the stop and chop technique. All throughout the surgery, the remaining host cornea and the Descemet's membrane were very stable and strong. But you can see that my tip of my phaco was always pointing downwards, so that I do not injure the endothelium, the host endothelium, because that would be gross. Now the remaining the cortex is washed using is removed using a bimanual. Rhexis is extended, and foldable IOL is implanted. So this is the host cornea. Sorry, this is the donor cornea, which is refined 8.5 millimeter. The endothelium was brushed off with a surgical sponge, and this is secured over the host bed with 16 interrupted etovitrial sutures. So post-operative day 1, the cornea was found to be edematous. The ASOCT revealed a DM detachment, so desmetopexy was done. And at post-op 6 weeks, the cornea was quite clear. Vision had recovered to 20/50 parts. This was DALC and phaco as separate procedures. Most of us do in our regular ORs, but for me, this was my first combined thing that I did. And believe me, I feel very accomplished when I look back at this picture. So shifting to a completely different topic, that is neurotrophic cornea. So neurotrophic cornea, meaning the sensation, we know that sensation is critical in maintaining the epithelial integrity, and reduced sensations can lead to frequent ulceration and perforation. So these are the causes and there are various treatment options. So, I'll be showing a case where we had a 38-year-old lady who presented to us with a history of redness and watering for the past 13 years. Diagnosis revealed a neurotrophic ulcer, and she had varicella infection during childhood. This is her photo. Corneal sensations were totally absent. She also had decreased sensation over her, absent sensation over her supraorbital and the supratrochlear nerves, dermatomes. Infratrochlear was present, intact. So this is the indirect approach where we harvested a sural nerve, about 10 to 15 centimeter. Now this is a blunt dissection of the healthy supratrochlear nerve. It is bluntly dissected and secured by passing a vicryl suture. This is the affected site. Now a tunnel is being made. The sural nerve is passed through this tunnel. Through an upper lid incision and blepharotomy, it gains access to the superior conjunctival fornix. Now the nerve is bluntly dissected to expose the fascicles. 360-degree peritomy is done. Small tunnels are made into the conjunctiva, into the cornea. The fascicles are now streamed as per requirement, and they are gently inserted into these wounds, into these tunnels, and left in situ. Conjunctiva is closed. This is the final procedure where end-to-side coaptation or an end-to-end coaptation is done. This is the sural nerve with the supratrochlear, with the branches of the supratrochlear nerve. This is the post-operative photo. So her sensations have started reappearing, and she can now feel sensation over her dermatomes. So this was a pretty long surgery of about 4.5 to 5 hours, which we would not have done in a regular OR. So COVID gave us an opportunity to carry out these procedures. So instead of worrying about what you cannot control, shift your energy to what you can create. So COVID made me a better ophthalmologist, a better surgeon, and starting from making dalgona coffee at home to making pizza for my son, baking cakes, I become better than average cook. Thank you for your patient listening.
Thank you, madam. That was a wonderful surgery display. Your diary is full of adventure and amazing surgeries. It is worth watching. Yeah, definitely. We all reinvented ourselves during the COVID times. Like we thought that without patients, we cannot survive. We came to know, yes, if the hospital is shut, yes, we can always stay back and really we can enjoy our good time with the family. Any other tips from our panelists, please?
Well, my first reaction was when she said, when life gives you lemons, I almost said, make martinis. And Dr. Sabyasachi is still in the hospital. But yeah, fantastic, fantastic presentation, ma'am.
Yeah.
So, are you still at the hospital?
No,
no, this is the background. This is our institutes which have kept it as a background.
Yeah, these COVID times is throwing a lot of challenging cases to us. People are coming with complicated cases like early cataract becoming mature, the moderate glaucoma is becoming advanced, and even the AMDs, those CNVMs, they're all becoming more advanced, and the prognosis was becoming bad because patients fear. So we have to reassure them and then make them to visit the hospital in such cases and to get a better results.
See, in Delhi, actually, I think we were doing things very early. So now we've started seeing what used to be the normal spectrum in the PG days, that we've started seeing now.
Okay.
In the last whatever 5-10 years, we'd stopped seeing mature cataracts, hardly any. So after this, we started seeing mature cataracts. That was a. So I don't know how was it, is anybody available from tier 2 cities? Like I don't know.
Tier 2 is slightly better, sir, like tier 2 and 3 cities, because the rules imposition is very less there actually compared to the metros and the bigger cities, where it was totally shut down. And it was, because media is everywhere in the big cities, they capture and then alert the authorities. So in that way, that is one thing. And because these small cities, people are not exposed to all these news kind of a thing, they kept on doing it in a very small, subtle way. And they were having small stream of patients, but not in main cities. I remember my hospital being in Bangalore, main areas were shut down for 3 months, except for telephonic this thing. And then gradually we opened up with telemedicines and teleophthalmology. And now it is settled now. But
I think, sir, the glaucoma patients were the most affected. They were the ones who were the most worried. And they were, really thankful when they managed to get hold of, somebody from the glaucoma stream.
Yes.
So,
true. The second surgery, the first surgery you showed, Dr. Smruti ma'am, like, you had a very Descemet membrane was present, almost, right? And you are doing phaco. Are there any change in parameters that you do, or you are afraid of the burst opening of the Descemets? Or the endothelium?
No, it was the Duas layer and the Descemet's membrane, so it was holding very strong throughout the surgery. Parameters were the same. So I did not have any problem. Throughout, touch wood. Anytime, if there will be any problem, definitely you have an eye bank with you. You can just convert it to PK.
Correct. So Dua was always helping you, the Duas.
Yes.
Dua, Hindi Dua.
Okay. One small query, like could we have gone in with, say, Bhattacharjee ring or, Malugen there?
Yeah, that would have been a good option. But it was Synechia all around. So because it was a post-keratitis scarring, so it was there were Synechia present because of the previous infection. So I just went ahead and released the Synechia, and as you can see, the pupil post-operatively was also not that dilated. So
yeah, no, ma'am. Actually, what happens is after the synechiolisis, like if with the BHEX, what happens is it takes lesser space, so it tends to it doesn't give you the kind of dilatation that a Malugen gives you, but it makes it more workable. You were working through a pinhole, so.
No, but still,
I
sir,
had all the time with me. So
great surgeon doesn't need any rings. Great surgeon doesn't need any rings.
Yeah, that's it.
Manage.
That's it. Yeah.
It's all the comfort level. The comfort level, definitely. The comfort
yeah.
level.
Actually, have stopped.
I was talking of replicability of the research.
Yeah.
So
Okay.
this is not,
is,
vertical chops and the small. The small pupil and you've already got a compromised cornea. It's like you need special cardiovascular status for it.
Okay.
No, but great surgery, ma'am. Amazing. Like,
thank you.
Now you need anesthetic not for the patient, not for the doctor.
Yeah. You need a physical trainer, you need a cardio trainer, and you need an anesthetist. Yeah.
Good. How is that Bhubaneswar? How is the system, madam? Like now as on today in Delhi and Bhubaneswar, because of Omicron related.
Bhubaneswar is quite pretty much the normal, and but in the first phase, actually Odisha was very strict. So because of our chief minister was very strict regarding the thing, we had all CRPF people and the police staff guarding. So we literally used to carry our eye cards and go to hospitals.
True.
In the month of April, I remember I had only 3 working days. From May onwards, but our hospital was open even on Sundays also. So we had a roster kind of a thing, and too much of a planning, and
Same.
the whole administrative, everyone starting from sweeper to the director. I mean, everyone was like coming on rotations and very strictly followed.
Dr. Shailesh, actually, I think this was the only state where the chief minister's own sister and the relatives, they went into a quarantine, and even the bureaucrats, they actually set up an example by following really strict and stringent rules.
True. Good. That's really good. That's a true leaders actually.
And so how's the situation in Bangalore?
Bangalore looks okay. In fact, we are the ones who introduced Amir Khan, that is Omicron variant. A doctor was affected, and a person who had traveled from Saudi or somewhere, and he left immediately to Dubai or somewhere. FIR has been lodged against that fellow, and the doctor was quarantined. Apparently, they attended a cardiology conference. The media sensationalizes these things. A doctor is a big spreader, or the medical conference is a big spreader, like Tablighi was done in the first wave.
Okay.
Same thing. And then afterwards, the doctor told, listen, I went only for 2 hours, and the next day only I developed symptoms. So you can't have such a sudden onset within 12 hours. So I must have had before only during my working place or maybe traveling, other issues. So don't blame just for the sake of it. Anyway, except for those 2 cases, we don't have any other cases. But the more and more testing has been done, and we are picking up a small number of cases. The practice almost remained the same, like it was picking up, and it is still in that level. We don't know in the coming days how it works. Delhi appears to be a bit scary, I suppose. How is it, sir?
Sir, I think we've got 4 cases reported from Delhi now, and the things are like the genome sequencing has been ordered on a very large number, but by and large, I think I was told it's only 4.
Good.
And all of them were like when the first one was he was totally asymptomatic, and I had a friend, he says ki hum usko chicken manga ke khila rahe because he wants to leave.
Oh.
So
Okay.
in fact, I have my dog calling me out now, so I'll beg leave.
Yeah.
I think
Sure.
so it's been a great session. Thank you, Dr.
Yes,
Shailesh. It was fantastic.
Thank you, Dr. Jitin Bali sir, Dr. Smruti madam, Dr. Sabhyachati sir, Dr. Anaga madam, and Dr. Satyajit Sinha sir, and also our KOS scientific committee to give this opportunity. It's a well discussed case, and thank you all, and have a great time. Thank you all.
Thank you, sir.
doctor.
Thank you. Bye-bye, ma'am. Good night, ma'am.
Good night. Goodbye.
Thank you so much.
So with this, we'll end this.